that is wonderful to see such a great turnout on the Friday evening. So thank you all so much, and you're all very, very welcome to Vasculitis Ireland Awareness first online conference. So you, as I say, we don't know from why you've registered and come today. You might be a patient, you might be a family person, a support person to somebody with vasculitis. You might be a health practitioner, a researcher. You know, for whatever your reasons for joining, I hope that you have an experience and that allows you to journey and find insights to the world of vasculitis. And Mike Clarkson is one of the specialists in vasculitis, and he's going to be the first speaker on, and I'm going to leave it to him to explain exactly what is vasculitis. That's so Mark. And then just a little bit before I hand over to Mike, just want to give you a little bit of background to the Vasculitis Ireland Awareness Group. It's a small charity. We were set up by a great person, Julie Power. She was the founder of Vasculitis Ireland Awareness in the north of Ireland. She was diagnosed with vasculitis, found there was very little support after her hospital care. So Julie just went about trying to find people in a similar situation. It's a rare condition, so that was difficult. She went to met people for coffee and decided on doing some fundraising. And that's really how the charity began in Northern Ireland, from our kitchen in Belfast, in Kinlaw. So that's the reason we're all here today, is from Julie's determination. Unfortunately, Julie can't be with us today due to family circumstances. So we really have to make double efforts on her behalf. For us, the change then that's come, we've become a cross-border charity since last year. We're now registered in Southern Ireland. So we're uniquely a cross-border charity, which is great. We have 5 members on the board, and they're all here. They're all online here today, as I say, apart from Valerie. And we have Philip. He's our latest volunteer. They're due to Philip, and he's really helping us become more technology savvy, and we're developing our website, we're developing a Twitter, you know, all the social media that we need to be current. And of course, in the current world of COVID, we're all being forced into the transformation. So keep an eye. We hoped we'd have the website launched, the new website launched today, but the time restraints and the resources, you know, we haven't got people on the ground to help do that. So the charity is involved with lots of aspects. What do we actually do? We're involved with many aspects of vasculitis around in the research, in education, about the delivery of the care pathways, policy development. And within all that, our 3 aims always remain the same. And that's to provide support to patients and to raise awareness around vasculitis and to improve the services and care for those affected by vasculitis. And that's what we're about. As I say, if anybody wants to become involved after the conference, just get in touch, and I'm sure we'll find ways for you to come and help us. So that's it. I hope, as I said in the beginning, that you all get something out of it. And of course, don't forget there's tomorrow's conference from 11 to 3. So I'll hand over to Mike Clark, Dr. Mike Clarkson from Cork.
I'll just introduce Mike there. Mike, I'll just give you just a quick introduction. So Dr. Michael Clarkson, a consultant nephrologist of Cork University Hospital, on the topic of vasculitis care during the COVID-19 pandemic.
Thanks very much to Trish and Co for inviting me. So I'm Mike Clarkson. I'm one of the kidney specialists in CUH. And I suppose along with colleagues here and around the country, I've sort of developed a keen interest in the care of patients with vasculitis. And I'm very grateful to be asked to speak to you all tonight. And I think it's a great endeavor that this conference has been put together. And I hope you derive some use from it. So this talk isn't very kind of scientific. In many ways, it just sort of revolves around the sort of advice that I'm giving to patients who turn up at vasculitis clinic. And it's advice of a kind of a general nature, but, just like all of these things, I'd give a kind of the rider that, for any one specific individual, you got to talk with your GP and your consultant. But, these might give rise to some questions or thoughts or practice that you might have, and you might want to talk with your own physician about. And I can take questions, I suppose, at the end. So this is the kind of, this is the person who's causing all the trouble. Okay, so this is a little sort of diagram or picture of what's known as the SARS-CoV-2 virus. So that's the severe acute respiratory syndrome, coronavirus 2. And it's the second one because there have been previous coronaviruses that have caused similar illnesses, but nothing on the same scale as COVID-19. So COVID-19 is the illness, and it's caused by this SARS-CoV-2 virus. And coronaviruses are kind of pretty widespread in the human and animal world, and they cause upper respiratory tract infections. But in the last decade or two, 2 or 3 different COVID viruses have arisen that have given rise to serious illness. MERS was one that came out in the Middle East some years ago, but COVID-19 obviously originated in China at some stage, probably at the latter end of last year, before sort of breaking into infamy in sort of January, February of this year. It's probably a virus that has jumped from a species. Okay, so it probably originated in bats. And because of the wild meat markets and the habit of consuming wild meat in some parts of the world, including China, it's probable that an infected bat infected human, and then the human propagated on from there. And we catch this virus, it is contagious, but it's caught by airborne transmission, so coughing and sneezing, and the virus staying in sort of suspension in little micro droplets of your sneeze or your cough in the air. And then somebody else inhales them, and it gets into your body via the lining of your mouth, the lining of your nose, and potentially the lining of your eyes. And I suppose that's why it's become the idea of wearing masks has become so important, both to prevent people spreading the virus and also from inhaling the virus. And I'll talk a little bit about that. But in this picture, hopefully, is the sort of what will get us out of trouble. Coronaviruses are called coronaviruses because when you look down an electron microscope, they sort of look like a crown. Those little spikes on the football-like core of the virus look like a crown. And those spikes are what the virus use. They latch on to the lining of your nose or your mouth, your throat, and then the virus gets brought into the cell or into the body. But they are super targets for antibody generation. So many of the vaccination trials that are underway are generating antibodies against those little red spikes that are sticking out of the diagram there. And we sincerely hope, and we're never certain, but we're very hopeful that in the next 6 to 12 months that effective vaccines will become available and that they'll be dispensed initially to higher risk groups and healthcare workers, and then out onto the whole community. So that's hopefully the cavalry is coming, as it were. I suppose from the point of view of vasculitis, and most patients or most people who are probably on this call have some variant of ANCA-associated vasculitis, but there are different types of vasculitis. But I suppose we use ANCA as a kind of surrogate for vasculitis. What impact has the pandemic had on the care of people with vasculitis? And I suppose in the first instance, there can be delays in diagnosis, particularly in the early phase of this crisis, because people were afraid to go to the doctor or couldn't get to go to see their GP. And what's also true is that, as many of you may know, some of the earliest symptoms of vasculitis are quite kind of non-specific aches and pains, fever, flu-like symptoms. And so people may have put this down to having COVID. They may have decided to self-isolate. They may have been slow to seek medical attention. And furthermore, they may have been slow to attend because of their concern about going into an environment that's enriched for COVID-19, places like hospitals, GP clinics, pharmacies, etc. I suppose for those patients who have a diagnosis of vasculitis, who typically would attend clinics on a regular basis, for a considerable period of time, we weren't able to run clinics, and we were running virtual clinics, either phoning people. But that's not quite the same as seeing somebody in person, and often you need to look at a person, you need to see them, you need to examine their joints, listen to their chest, to get a feel for whether how active their vasculitis is, because it's quite a subjective thing. So virtual clinics, while better than nothing, are certainly not as good as an in-person clinic. And obviously, again, delays in getting investigations done. And I mean, patients with vasculitis, I suppose, share a lot of these difficulties with anybody with a chronic illness, but it's true to say that the pandemic's had a major impact on how we deliver services, and certainly for 2 or 3 months at the sort of late March, April, May, we were very nervous about bringing people into the hospital, particularly immunocompromised people on treatment, but over the summer months, the wave, kind of went away. And we got a little more confident, and clinics got up and going again. So obviously there's a nervousness again now, and I think it kind of behoves all of us and the wider society to try and get to grips and keep the infection number down as best we can. I suppose this is just a kind of a slide, just more to say, what do we know about COVID? Well, if you think about it, we know very much, and we can't know very much because it hasn't been around very long. It's really only been 7 or 8 months that we've been coming to grip with this. So, what we know is kind of like a water drop in what's out there to know is, there's so much we don't know about it. Yeah, we only know a fraction of what we need to know. But again, I'd say never in the kind of course of human history have so many people been working so hard across multiple countries, all of science, all of government, international community, to drive on. And in some ways it's remarkable how much more we know now, and how, to some extent and to a great extent, how better prepared we are now than we were back in March. I suppose what you may want to know, and the kind of golden question I would have thought would be, look, I have vasculitis, I'm maybe on immunosuppression, what's my outlook if I happen to get COVID-19? The information here is really pretty scarce, and that may be for 2 reasons. And the primary reason is probably when the alert first went out that, there was a new virus, that it was infectious and contagious, our first protocol in terms of telling people to be careful were people who are immunocompromised. So in some ways that was so effective. There have not been many cases to date in patients with vasculitis. So there's very little published in the literature about this. There have been very few cases in Ireland to date, and certainly none that have been sort of shared in publications. There's obviously concern that people with immunosuppression may do worse, and there's uncertainty about what to do. What do you do with somebody, for example, who's on Imuran or azathioprine, or what do you do with somebody who's on some steroid and mycophenolate, or the drugs that we typically use for vasculitis where they get COVID-19 infection? And while we have a kind of a strategy laid out, and some of this is learned from patients with solid organ transplants who are typically on a similar level of immune suppression, we can't be sure. And in some ways, the fact we're not sure reflects the fact that actually you guys and your doctors and the people who care for you have been pretty good at preventing infection. What we do know, though, is, and this is from international data, is that people who are on very high doses of steroids tend to have more severe disease when they first present. But having said that, and anyone who's seen just how crazy Donald Trump is in the last few days, he's been on very high dose steroids, having had what was possibly quite severe lung disease. And we know that if one gets COVID and if one gets severe lung disease, that the outcomes are significantly better if you're given high dose steroid. And that's probably because what happens with COVID is you get a viral infection, and in a smaller proportion of people who get infection go on to get a more serious disease. And when they do, it may not be so much that the virus is causing damage, but one's own immune system sort of spirals out of control or spirals into a sort of an inferno-like inflammatory state in the lung that causes direct lung injury. And it seems that if you can tamp that down with high-dose steroids, it may be beneficial. So the timing of when you get the steroids is important. If you're on high-dose steroids when you initially get the infection, you may have a higher rate of viral replication and a higher viral load, which is probably not good. But once this sort of hyper-inflammatory response occurs, this over-exuberant reaction to the infection occurs, steroids can seem to be able to damp it down. But having said that, and I suppose the goal of this talk is to kind of look on the positive. In all of the published data in vasculitis, rheumatoid arthritis, autoimmune diseases, the majority of individuals with inflammatory disease, the majority of people with solid organ kidney transplants recover from COVID-19, okay? And the majority of people who develop COVID-19 recover. And this is kind of a catastrophizing that occurs on the TV where, you know, a lot of focus is put on where things are going wrong or where things go bad, but it's important to understand that the vast majority of people, this is a transient illness in which they recover, and the majority of people who are hospitalized, and even in Ireland, the majority of people who end up in intensive care survive. In terms of, you know, what happens, what we know about vasculitis and COVID-19, you know, I suppose a lot of patients with vasculitis tend to be older, okay? So the median age of onset of vasculitis in Ireland, you know, is in the sort of late 50s, early 60s. Often people have kidney involvement and high blood pressure goes along with that. And sometimes vasculitis, as you know, can affect the lung. So even if one is not on immune suppression, or if one is, patients with vasculitis tend to be in a higher risk group, and you guys have to really be careful in terms of doing your best to avoid putting yourself in situations where it might be possible to become infected. And that holds true for those who you live with and who you interact with on a day-to-day basis. So I suppose some practical questions. You know, I've just said that, you know, steroids are, you know, using steroids associates maybe with doing a little worse if one catches COVID. Should I stop my steroids? So the straight answer is no, never ever stop your steroids without talking to your general practitioner or your treating consultant, okay? As it is, the amount of steroid that we're now using in patients with vasculitis is significantly lower than it used to be. And that's because of clinical trials that have been published in the last year. You may be aware of a big trial called the Pexavas trial, which it was involved hundreds of patients around the world and compared a high and a low dose steroid protocol for treating either major relapses or first presentations of ANCA. And they showed that starting at doses about 50% of what we used to start with, people do just as well. So we're using less steroids than we need to. And the other issue is that if you stop steroids, you can become unwell because you may need them to feel well. If you end up having a relapse, you end up back on more steroids. So as best we can, your treating doctor is probably going to try and get you down to a safe steroid dose. And as I said, if you're unfortunate enough to get COVID-19 and doubly unfortunate to become unwell with it, you would probably end up getting a high dose of steroid to help you get better. What about rituximab? Many of you may be taking rituximab as a maintenance treatment, or you may get it in setting of relapse, or even as the first line treatment. It's a really effective drug in maintaining ANCA remission. As you know, you tend to get it every 6 months if you're getting in remission and you get a little burst at the start. Again, there's very little in the literature to say how patients with who are on rituximab do. There was only literally 3 cases identified that have been published, and one person did well, one person not so well, and one person in the middle. So again, I suppose a problem with rituximab would be that once it's administered, and its effect lasts for up to 12-18 months. So if you're on a medication that you can withdraw, like a tablet type of medication, that makes it easier to stop it in the context of an interval illness. But rituximab is, once you've got it, its effect is very long lasting, and that factors into how your doctor may decide to treat you. And there's concern again about rituximab and vaccination. Patients on rituximab tend not to respond very well to the flu vaccine and may not respond very well to the COVID vaccine if it's coming down the track. But again, vaccination works also at a kind of public health level, that if those around you are vaccinated, they will offer you protection by default. And then azathioprine or Imuran or mycophenolate mofetil, which is Cellcept or Mycolat. So again, never change your meds without talking to your doctor. If you got severe COVID-19, if you ended up in hospital with COVID-19, they probably would be stopped temporarily. And again, it's not clear that if you're on a low dose steroid and some azathioprine, mycophenolate, that actually your outcomes are any worse than they would be for somebody of your similar age and size and blood pressure. So it's not clear yet, but it would, again, sort of prudent advice and basic principle advice would be that anyone on any form of immunosuppression would be considered a high-risk person and should try and, as best they can, do their best to avoid COVID-19. Probably the most common question I get, and again, I work a lot with patients, kidney transplant patients and vasculitis patients, are questions around work. What should I do? Should I go back to work? And again, that's a really difficult conversation to have with somebody, because the easiest thing for me to say is to be, well, no, don't go to work, stay at home, lock yourself in a room. And, I can be pretty confident that you won't get COVID. But let's be honest, that's not a pragmatic approach to life. And I would associate with, serious adverse outcomes in terms of people's mental health, their financial health, so people have to make kind of pragmatic decisions. And I'll show you this is my approach to it. I can't say it's the right approach, but this is the approach I do. And again, this is more maybe to inform your discussion with your GP. Every decision we make, whether it's COVID, whether we're pre-COVID and we're going out to the shop, involves risk. There's no situation that doesn't involve risk, and I think as doctors, we're quite used to making decisions or working with patients to make decisions to take balancing risks and benefits of treatment. And most people in their day-to-day life don't have to do that, and they're typically, people aren't great at it, but we're all having to get better at it now, regardless of who we are or what our background medical history is in the context of COVID. And these decisions are important, and they often affect somebody else as well. So this is the kind of advice I would give you if you came to see me in clinic. And again, I would say, while patients with vasculitis as a group could be considered a higher risk group, again, there's probably levels of risk within that. So we would say there are high level, sort of highest risk, medium risk, and low risk vasculitis patients. So a highest risk patient would be somebody, for example, who's just recently been diagnosed, who's been on high dose steroids, maybe recently received rituximab or cyclophosphamide, and is in the first few months after diagnosis. A medium risk person might be somebody 2 or 3 years out from original diagnosis, still on immunosuppression, maybe 5 milligrams of prednisone, maybe azathioprine, who's otherwise well, but is on immunosuppression. And perhaps a lower risk person might be somebody who's thankfully off all immunosuppression, but maybe has some residual damage, either kidney or lung, or maybe somebody who's on very low dose single agent immunosuppression on 5 of prednisone or 50 of Imuran, something like that. So just think of kind of within the family of people with vasculitis, high risk, medium risk, and low risk. And this is what I kind of do. I think you got to look at the person in terms of what is their job, and you've got to look at what the local instance of COVID is. Now, if we were to go back to, say, the start of July, the end of June, the incidence of COVID in Ireland was really very low. And there are certain parts of Ireland where it still is very low. And then there are other parts of Ireland where it's high, so at the moment, Donegal is high, maybe Cork is medium to high, Kerry is still kind of low. And you've got to kind of keep an eye out for your own local area. And then there's kind of what your occupational risk level is, So, and again, this is probably for a kind of a medium risk person. So this is somebody who's on 5 of steroid and 50 of Imuran. a low risk occupation. So if somebody comes into me and they're a farmer and they're sitting in their tractor driving up and down the field, you're not going to catch COVID from the cows. That's a very low risk occupation, and they can pretty easily maintain social distance and avoid going maybe to the mart, so that's a low risk. So even if there's a lot of or medium amount of COVID around or low around, they're probably fine to go to work. If there's very high incidence in the local area, a yellow is kind of beware, okay? However, a medium risk job, so say somebody's a teacher where they are having some face-to-face time with students, or working in a shop where there's face-to-face time with customers, if there were a very high prevalence in the area, red means probably better, maybe steering away from that. Or, often particularly bigger employers were able to put you in an environment where you would have a lower occupational risk exposure, and it might be possible to consider going back to work. And again, a high risk job, these would be, the classic example would be the nurse. Again, a lot of our nursing staff have had to go off work because they're immunocompromised, and just the risk environment in the hospital is too high. So that would be for a kind of a medium risk person. So it kind of depends on how much COVID is circulating, and kind of depends on what you're doing, okay? Again, if you're taking somebody who's lower risk, it's a lot easier, right? So, if you're not on any immunosuppression, if you're not, don't have a big advanced kidney disease as a consequence of your vasculitis, you're probably in a much safer area, and even, the farmer can keep plowing his field or keep minding his cows, even if there's a lot of COVID going around in the community, because he's able to socially distance. Again, the teacher, maybe at very high prevalence, or if COVID comes into the school, they might want to think, well, should I not go to work? And again, with very high, higher risk people really can't come back to work unless COVID is essentially being suppressed, and that would have been kind of where we were back in June. Again, if this would be for a higher risk person, here really, certainly in a high prevalence, where there's a lot of COVID circulating, nobody should be at work. You've got to be off. You've got to be, it's a terrible word, but cocooning. And again, that probably holds for medium risk, medium incidence level too. So, it's more likely than not, if you're in the first few months after diagnosis, or you've been on heavy immunosuppression, that probably your doc's going to advise you not to go to work. And I think that's kind of this is kind of the advice. I don't show this graph, but this is kind of the advice I've been giving people. And I think it's a reasonable balance between the need to go to work. We're social animals, it's very important for our mental health that people get out, you can have a kind of an adult conversation with your doctor about that. What you don't need to do, these are certain things people are doing who come into clinic. People washing their groceries, putting their groceries in the garage for 2 days and then bringing them in. You really don't need to do that. If you're washing your hands, if you're wearing a mask, again, if you're in that kind of red zone, somebody else should probably be doing the shopping for you, because there's no real great need for you to go out into the world. You don't need to sleep separately from your partner, not for COVID anyway. And, you've got to assume that the people living in your house are within your little, they're within your little hub and cocoon. And, again, as long as they're taking precautions when they're out, when they're washing, their hands, when they get home, that should be sufficient, because you can't really socially distance from your husband, your wife, your children, However, if somebody in your household becomes unwell or develops a fever, it is prudent that they self-isolate from you as best they can, okay? So that they go into a bedroom, and that maybe you try as best you can to stay clear of them until such time as And again, not this, everyone's circumstance is different. You might have some, somewhere, again, you've got to do it as best you can. And there's so many different variations of how people live their life and family networks of how easy that would be for you. What you really need to avoid, and this is, again, I emphasize this to everyone who comes to clinic, because they're sitting in front of me having a conversation in closed confined space, this is something you need to avoid. So do not find yourself in a taxi with 4 other people. Do not find yourself in a room unmasked with other people. because that would be a high risk kind of activity, you know. So the 3 C's: conversation in closed confined spaces. If you find yourself in a closed confined space and you have no other option, like you're going to clinic or there's something essential, you and the other people in the room should be masked, okay? And that will really dramatically reduce your risk of catching the infection if somebody in the room is infected, okay? So it's the 3 C's: avoid conversation in closed confined spaces. And in fact, that's nearly the most important slide of the day. I think from a mental health point of view, I mean, I'm kind of concerned, you know, Ireland is, we do seem to be, certainly if you read RTE or read the paper, you'd think, you know, the end of the world is nigh. And, you know, honestly, I don't think that that is the case. And I think it has implications for, particularly for people who are higher risk, this constant drumbeat of bad news, you know. And I think psychologically, I think it's a lot of this you can't control. You cannot control the number that comes up on the 6 News every night, you know. You need to focus on the things that you can do, that you can affect, that will be of benefit to you. So ensuring that you and the people near you hand wash when they come home. Wear a mask, and we'll talk a little bit about visors. You know, cough into your elbow, make sure people around you cough into your elbow. Avoid large gatherings. You know, unfortunately, a wedding is not the place at the moment. You know, again, if open window, if you're in a closed confined space and you have to be there, you know, ventilate it as best you can. Open the windows, open the door. Get outside and exercise. You will not catch COVID walking, you know, walking down the road as long as you socially distance from people. You know, get out, run if you can, cycle, whatever, you know, get out and about. You know, this thing that came out in the first phase of this, where elderly people really hid at home and wouldn't go out, you know, that is not a good thing. You know, get out. You know, one of these things is not like the other. Okay, so I really strongly discourage you from wearing visors. Okay, they offer very little protection to you, and for those people, if somebody around you is wearing a visor, really the masks operate on the principle that you're protecting other people, and we're all protecting each other. The visors offer very little protection to anyone. Visors, and you'll see them on the news. Well, why then are the nurses wearing them in ICU or at the front door of the hospital? The reason they're wearing them is they're also wearing a mask, and they're wearing the visor to stop somebody, an unwell patient who can't control themselves, coughing or sneezing into their face, where they would get a huge droplet load straight onto their eyes, and that would put them at risk of infection. So really, it's a kind of an additional extra. But that guy on the left there is not protecting those around him, and he's getting very little protection himself. And I don't think, certainly in the news and so on, there's not enough emphasis on that fact, because I'm seeing more and more people in the shopping centres and so are wearing visors, and they might as well wear nothing, actually. And don't focus on the following. You know, what level are we at? When will the vaccine arrive? When will it all be over? What are the numbers tonight? How many have died? How many have not? You can't control that, you know, and, you know, focus on what you can control. You know, we can't control Ireland losing last night. We can't control Liverpool losing 7 goals against Aston Villa, which is just hard to believe, but true. So focus on what you can, but what you can control. You know, focus back on these things. Just do the simple things well, and that'll provide you with protection. You know, I've worked in the hospital now since May. I've had patients with COVID. I've been in and out of rooms where patients have COVID infections, and neither I or any of my team have caught COVID because we stuck to doing the simple things well: hand hygiene, personal protective equipment, wearing our mask properly, and being careful. You know, and we haven't caught it. And an interesting fact is, the part of the hospital you're least likely to get COVID in is the intensive care unit, where the COVID patients were, because people there were just kind of did the simple things well. You know, if we let our guard down out and about the house, you know, or when we're out, that's probably when we're going to catch it. And another important thing would be kind of when people come to your house, you can catch COVID from, you know, a family visiting your house just as easily as you can catch it from a stranger delivering your parcel. So if somebody has coming over to your house and they're a family member and they're not living with you, they have to wear a mask. Okay. I know I'm running over my time here, so I'll scoot along. What would I do if they lock us down again is get a dog, because I want to get out and walk them. Exercise. I'm really glad to see that the next talk is on exercise. I think that's really important. And if we do get shut down and the winter closes in, let's get out and about and exercise as best you can, and, you know, eat as best you can. You know, bad advice: you're vulnerable, stay inside, don't go out. That's bad advice. Get out safely. Get your blood pressure down, lowers your stress levels, gets feeling better. Get out, maintain social distance when you are. Just stand back from people, exercise. You'll feel better for it. Keeps your muscle strength up, releases, you'll sleep better. The more exercise you do, the more energy you'll have. Resting, well known to kind of worsen your exercise capacity. And it'll help you sleep better. And the kind of key thing, keep your mind. This is a kind of do puzzles. Keep your mind active, keep physically active. Buy a dog and do the crossword if you as best you can. Like keep active, keep mentally active, keep physically active, and focus on the things you can control. And that's kind of it.
Thank you very much, Dr. Clarkson. I think we can all say agree on that was fantastic and very, very informative. Thank you so much. That was brilliant. So guys, I'm just going to quickly share our today's agenda.
Sorry, Philip, can I just come in?
Yeah, is there a question there?
Are we having a question there? Yeah.
Was there one question in there? Yeah, I see one question there in the chat. I'll just read it out now. What about, for instance, having a high dose of steroids for a joint or lumbar problem, i.e. a spinal epidural?
So again, it would sort of depend on the dose that they're giving you. So people tend not to kind of get, have the sort of, I would think that's kind of a lower risk thing, while the local dose of steroid that's given is high. It's probably not in the realm of what people are getting, and again, I probably wouldn't not have a steroid injection for a joint or lumbar problem, I wouldn't think I would think that's probably unreasonable, to start trying to avoid that. I would go ahead with that,
Okay, that's great. Mike, can you just give us the 3 C's again from your, what did you call it?
So conversation in closed, confined spaces. So, finding yourself in a small room with poor ventilation with a couple of people, the lift, finding yourself in a lift, with 4 other people.
Yeah.
Or a car, So, I had a patient with vasculitis who wanted to work, and this was at a time where, the incidence was low. He'd be a medium risk person. It was in construction, and he said, look, no problem, I can work, I'm fine, I can keep my distance, where, it was kind of heavy duty construction. And then I asked him, how are you getting to work? And he said, oh, me and 2 of the lads go in the van. So like, yeah, so I said, look, you can go to work, but you got to drive yourself, and just think like being careful at work, but then getting in the van, being very meticulous, but then having your daughter come over and sit down and have dinner, and you've got to think that's not somebody of your household, and it's difficult, but you've got to try and maintain social distance from them, just the same way you would maintain social distance from the mailman,
Yeah. Okay then, Mike. Well, that's super. Thank you so much. I think it was an important message considering the climate we're in today. So I'll hand back to you. Thanks, Mike.
Yeah, no problem. Thanks for inviting me.
Dr. Clarkson, that was fantastic. And thank you, Patricia, as well.